Oh, hello, everyone. I'll go ahead and get started. Thank you for joining Grand Rounds today. We have a speaker with the child and adolescent focus. And I'm Chandra Cullen. For those who don't know me, I'm the Vice Chair for the Child Psychiatry Division. So we have Dr. George Davis here today to speak about failures and solutions in New Mexico Child Protective Services, the Kevin S. lawsuit. Dr. Davis is a child and adolescent psychiatrist who works primarily with underserved populations in New Mexico. Dr. Davis previously served as the Vice Chair for Child Psychiatry at the UNM School of Medicine, Medical Director of the Children's Community Mental Health Clinic, and Director of Psychiatry for the Department of Children, Youth, and Families. His areas of expertise include systems of care for seriously emotionally disturbed children, the treatment of delinquency, and the extended effects of child abuse and neglect on neurodevelopment. He has published in the areas of child maltreatment and its relationships to subsequent criminality. So we're very pleased to have Dr. Davis here today.
Thank you, Dr. Cullen. I assume that I can put my own slides up. Oh yeah, I see that I can. Are those coming across okay?
Yes.
Trying to make it into a slideshow. There we go. Thank you, Dr. Cullen. I appreciate that. And I will say that I'm usually, I work with lawyers so much on this lawsuit. I'm one of their clinical consultants that my wife always asks me whenever I do something alone, aren't you taking your lawyer with you? So, and I have to remind her that these are not my lawyers. They're people I work with. But it's a very good group of people. What I hope comes across, what I hope the take-home message from this whole thing, this whole discussion is how much we need and depend on a functioning child protective system in New Mexico. We need that not just as citizens and people who care about children, but as advocates and also as clinicians. We need this system to function. And so I hope that comes across in our discussion about reforms for this system. Just housekeeping. I take it someone would tell me if my audio is having problems, but I'm going to assume it doesn't if I don't hear. Housekeeping, I don't have any financial disclosures to make. I'm not selling anything, and there's no products that are used for the purpose of child abuse. And the purpose of the lawsuit itself is purely for system reform, not for damages. Learning objectives, the things I hope we get out of this are the improvements that are necessary for a functioning and healthy child protective system, and the essential roles that both HSD, Medicaid, and CYFD play in an adequate system. The primary aims of this lawsuit, which is, like I said, purely for reform. The progress that we've made, there are progress reports on this, and there's monitors that are checking our progress, and the difficulties that are intrinsic to multi-system reform, the complexity of it. And finally, I hope it comes across too, is that how does this affect you? What does this mean for you as clinicians, psychiatrists, psychologists, pediatricians, and all those who are seeing this, seeing children? The original Kevin S. lawsuit was a class action lawsuit that was filed in 2018 against both Children, Youth, and Families and the Human Services Department, which is basically Medicaid. There were 14 original plaintiffs. These were all children who were in custody. Kevin S. was a pseudonym for the lead plaintiff, as is customary on class action lawsuits. Some of these children were in custody at the time. I guess all of them were in custody at the time, and some of them have since aged out. And the complaint assumed, as the basis of the complaint, that Child Protective Services in New Mexico, but in any state, actually, when they assume the custody, the legal custody of the child, that they're obligated to exercise the same oversight and concern for that child as a parent might. That's the underlying assumption. The complaint, the original complaint against both CYFD and HSD alleged systemic and structural failures. Systemic meaning it applies to virtually all the children in some form or fashion in the state, and it applies equally in Raton and Las Cruces and Albuquerque. And so for that reason, it's considered systemic, and it's also structural in the sense that the way CYFD and HSD are organized, their way of doing business, those problems are baked into their organization and need to be addressed systematically. Specifically, they said the lack of secure and stable placements led to multiple changes of placement, which worsens the condition of children who are already traumatized. Also, there's not a functioning or adequate provider network to provide medical or mental health services to these children. And then thirdly, because these are all by definition trauma victims, both because of what they experienced prior to taking custody and because of the fact that they're in custody, they've been separated from their primary caretakers. All these are trauma victims, and the allegation was that the state lacks information and expertise to construct a system that is useful for that. When this was filed in 2018, it was heard at the beginning of the current administration, the Lujan Grisham, and they agreed with us. They did not argue this in court. This did not go in front of a judge. They agreed with the complaint and said, let's make an agreement out of this. And so that's what it is now. It's an agreement. It's not a consent decree. A consent decree would still be under the supervision of the court, but instead this is an agreement between the state and the plaintiffs. Like it says at the very bottom there are people overseeing monitors on this agreement that are controlling the decisions about whether or not the state is succeeding. Those monitors are called co-neutrals, meaning they're neutral toward both sides. They're three experts, national experts in systems of child welfare. And there is a measure of when the state, on an ongoing basis, there's a number of deliverables, which I'll talk about in a minute. Deliverables meaning requirements, concrete requirements that have to happen. The measure of success is defined as good faith efforts. And I want to emphasize that that sounds like a moral, ethical term, or maybe an attitude or something like that. It's not. Good faith efforts means that every reasonable effort to achieve these targets has been made. So it's not subjective intentions or attitude or promises or anything like that. And how do they perform? This is the report from the co-neutrals that came out near the end of 2022, but it's really about 2021 deliverables, and that's because there's an annual reporting cycle. And so what I'm presenting here as the report came out for 2021. There were 16 implementation targets, which I should define. I should have defined that before. There's implementation targets, which are plans or preparatory work that needs to be done before these reforms can be implemented. And there's target outcomes, which are the concrete results of that implementation. The two departments together met 7 of the implementation targets, meaning the planning cycle, and they didn't meet any at all of the 31 target outcomes. Now, that full report is available here. All these reports, I put them on the slides, which I assume you'll get copies of, in case you want to look at that, which might be surprising that some of you might. What I would say about the departments is it doesn't mean that there was no progress at all. It means that there was a long lead up to this. When you try to hire adequate staffing, when you try for Medicaid to increase their network coverage, the quality of their services and the kind of services, there's a long run up to that. Feds have to approve Medicaid services. The state has to approve funding. And so it doesn't mean that nothing occurred, but it did mean that they are way behind. And then how does this agreement affect you personally in your work as a clinician at UNM? One, it affects the numbers. There are no clinics or inpatient facilities that are seeing children routinely that are not seeing children who either have been in custody or will be in custody or at risk for it, or are currently in custody. Secondly, it affects the acuity and severity, meaning histories of abuse and multiple changes of caretakers, which is one of the allegations, one of the claims, are strongly associated with symptoms of distress. I mean, I can't think of a simpler way to put it. We all know from the Adverse Childhood Experience study that early childhood trauma and adversity is remarkably connected to later functioning. And I'll talk about a little bit. This is not a clinical talk, but I will talk a little bit about what that is. But there's more anxiety and depression. There's certainly more self-injury. There's more suicide threats, more suicide attempts, more suicide completions, more trauma spectrum symptoms overall. Thirdly, because these children are more compromised, there's more services and medications that are required. The medications that are used are oftentimes specifically for the effect they might have in de-escalating or in reducing agitation. They're not really for abuse and neglect per se, but a lot of effort goes into containing the sort of dysregulation that children who have been abused have. You know, this is a terrible thing to say, but they have more difficult courses and poorer outcomes oftentimes, because it's not exactly a medical problem for which a medication or a therapy has been designed, although there are many great trauma therapies. And then how does it affect the hospital system? And by the hospital system, I mean us as a whole. I mean, it's not only Children's Psychiatric Hospital, but UNMH, the emergency department at UNM, PED, PES. When children in state custody enter the emergency room, they oftentimes do not have a place to return, which is part of the requirements of this lawsuit, as I'll go into in a minute. Placements is a big part of this. They oftentimes don't have a secure place, partly because of their behaviors or their externalizing behaviors, and partly just because of the fragility and insufficiency of those systems. And consequently, they get hospitalized at a higher rate, not always because of the clinical condition, but sometimes because there's no other choice. I think anyone who's been in the ER at night and seen these, I don't know how many sleepless nights you all have spent on this kind of question of kids in the emergency room, but most of us have spent a lot. And so lots of ER physician time goes into efforts to safely discharge that patient. More medication is prescribed. And there's lots of national studies that document that children in foster care are given a lot more medications, not always legitimately, but always with the best intention, of course. It leads to bed spacing because PZD, when CPH is full or tied up with children just like this, PZD will bed space those children into the main hospital of the children's unit. And then finally, length of stay at the time of discharge. Once again, the problem with placements reemerges. And because these children are difficult to place, the length of stays are longer. It is a real conundrum about how to get these children taken care of and safely discharge them. What are some of the demographics? These are brief and there's not a whole lot, but we know that 3,000 to 4,000 kids during most reporting years are in custody at one time or another. You can see that that number is decreasing, and I'll address that in just a second. It's not exactly a stable number, of course. There's a lot of children entering custody and a lot of children leaving custody, so it's not exactly a static population. And you can see also that from 2019 to 2021, the 3,881 was reduced to 2,949. Is this reduction good? I don't know. And we don't always know, because the department's greatest challenges, the greatest criticisms, and biggest lawsuits and awards have been because of children who were not taken into custody, children who suffered damage from not being taken into custody. But we know from the figures, we know this for a fact, that a lot of cases that are taken into custody are purely a matter of parental misinformation, misunderstanding, poverty. And so there's lots of cases on the other end that are unnecessarily taken into and could be handled otherwise. So the question is not, should they take more or should they take less? The question is identifying and taking the right cases. It's not on this slide, but we know that 51% are male, 49% are female. That's a relatively standard population, static, meaning it's a stable number. 45% of those kids are between 0 and 6. 25% are between 7 and 11, and 30% are between 12 and 17. You probably are more often seeing children at the upper end of this. And the reason why that is because child maltreatment is a developmental disorder. It rolls out over time. Just once again, as the ACE study says, you know, it's the lifetime of this that is damaging. So you as adult psychiatrists are also seeing these patients, frankly, as well. These are patients that stay in the system a long time. And just to further look at the demographics, the Hispanics are overrepresented in the system. White, Anglo are underrepresented in the system. American Indian, Alaska Native, it depends. There's 7%, which is a slight underrepresentation based upon census figures for the total number of these populations in the general population. And as we all know, that the census, the people who enter the census are self-identifying. So this is what these individuals identify as. American Indians are, Native Americans are slightly underrepresented. African Americans are slightly overrepresented. If you take the census figures to be accurate, which is probably around 2.3% of the population, and they're 4% here, so they're slightly overrepresented. I say just as a reminder that this children in custody, it's not a stable or fixed number. The way the department acts has a large influence on those kinds of numbers. It has big edges, meaning there's a lot of kids who are at risk for custody. You're seeing a lot of those. There's a lot of kids who have been in custody and are in custody. And so the number itself has much bigger edges than the 3,000 or 4,000 you're looking at. And the other thing that affects those is that a lot of time in-home services, supports to families that are not making it makes a big difference as to whether or not they come into custody. There's a lot of alternatives to custody. Sometimes there are no alternatives at all, and custody should be taken immediately. But there's also many alternatives for those families that are not functioning and they respond. And then what's the clinical condition of these children in custody? I've already said that they have more symptoms, and they are more, oftentimes more acute, have more severe kind of dysregulation is the word that we usually apply to this. Caretaker separation, without a doubt, is universally recognized in child development literature as a developmental catastrophe. Children by the very, foundation of child development require a devoted and present and consistent caretaker to develop normally. It just doesn't work without that. And therefore, children who are separated from parents are by definition suffering from attachment trauma. It may be just a word to some, but that's probably the most significant you can say about this population. The most significant condition you can say is it has lifelong and developmental consequences. This is made worse when there's multiple placements, which happens a lot. I will see kids that have 10, 12, 15, or more placements in the course of their stay with CYFD. I've seen kids who have more than 30 in the course of their stay. You realize what that does to their attachment capacity. I won't even go into it. Custody itself puts the kids on a trajectory. That's all I can say. And it takes a very strenuous kind of intervention to avoid that. What is the trajectory? It starts in Child Protective Services. Oftentimes these children have problems in school. They end up in special education, not because a lot of them have learning disabilities, but because of their dysregulation. They can't pay attention. They can't sit still. They get into more fights. They don't learn as easily because they're oftentimes hyper aroused. Because they don't get, quote, fixed in school, they move into the mental health system where we formally see them, although a lot of child psychiatrists, I think, are seeing them in the school system as well. And then if those conditions are not successfully addressed, they end up in the juvenile justice system at a much higher rate. We know from our own studies here in children who are at the deep end of the juvenile justice system who have been incarcerated, we know that well over 90% of those children are victims of trauma. And that's retrospective. We really don't know at this time how many children who are currently in custody or at risk for custody end up in the juvenile justice system. But retrospectively, it's a huge number. And usually this is due to that same dysregulation that I'm talking about. I just put down attention deficits, which are, oftentimes mistaken for ADHD, affect instability, which is oftentimes mistaken for bipolar disorder, which is one of the reasons that mistaken diagnoses are one of the reasons they tend to receive more medications. They're more impulsive. I could have filled up the entire slide with conditions. A lot of them are frontal discontrol, meaning they don't plan well. They don't see the future well. They don't have solid or easy interpersonal relationships. They're overreactive, hyperreactive. All of those things fall under that developmental dysregulation. And if you look back, once again, if you look retrospectively at the kids in the juvenile justice system, 65% of the kids in the juvenile justice system had one type of referral to Child Protective Services or another. Almost 80% of the females who were incarcerated had at least one referral to Child Protective Services. 53% of those were substantiated. And of the males, 62% had histories of contact with Child Protective Services. I want to comment, what does substantiation indicate? You might have the impression, common sense would tell you that means, did this abuse happen or not? That is not at all the truth. There's one major study that I didn't put on the slide here. They took 576, almost 600 cases of reported child abuse. 47% of those were substantiated in this particular group. I don't know what state this was. It was not ours. 47% were substantiated, but when they went back and combed through those, they realized that only 8% really had not happened. Substantiation means, can you address it in court? Is there enough advocacy for this child? Is there enough legal time? Is there representation? Is there court time? Can the system bear all those? And that is a very high mark, because a lot of cases that are perfectly obvious clinically are not able to be proved in court. So since CYFD screens out a large number, they substantiate at the least as well as I can figure it, and they substantiate like 20 to 30% of those. That means their error rate is more like 8 to 10, an order of 8 to 10 underrepresentation of those kids that actually were abused. And of course, just to state, something positive, I don't like to, I hate littering my slides with just, bad pieces of news, but the opposite is also true. We know that solid, devoted kinds of care, as it says here, warm family relationships and positive home environments, increases the resilience of children, even if they experience other kinds of trauma later. So it works both ways. And what that means also for us is that if we can create better placements for these kids, they have a much better chance. If they have a solid, secure placement with a secure caretaker, they have a much better chance. Now, the reform. CYFD and HSD have data problems. I mean, that's the nicest way of putting it. They don't collect good data. They never have collected good data. We've known this for a long time, and their capacity is very limited. The current data system for CYFD is called FACS. That's Family Automated Client Tracking System. It's 25 years old. I can remember Bill Richardson trying for two sessions of his, 2 terms of office, tried to fix that. Susanna Martinez said she was going to fix it for both terms, and now Michelle Luan Grisham says she's going to fix it. It has not been fixed yet, but they are in process of doing this. So a model was needed. If the co-neutrals were going to decide if these benchmarks were made, they needed a record keeping, and that record keeping became a data validation plan. And the data validation plan was one of the deliverables, the requirements that was mandated prior to even starting the reforms. You have to have good data if you're going to make that. It includes methodological definitions, but it attempts most of all to reduce this avalanche. As I told you, there's 31 target outcomes and 17 implementation targets, and it attempts to reduce those to metrics that can be measured objectively. But of course, there's qualitative measurements as well. For example, one of the requirements of the agreement is that the department, CYFD in this case, had to create and begin to use an effective, reliable and tested as well screening instrument. And so part of the metric on that is, did they do it? The simple number of times that they did it on every kid that was in custody. But the qualitative metric is, did they do it right? And secondly, was it used to drive care? Those are the qualitative metrics. Finally, the co-neutrals don't only judge by the metrics itself or by the data validation. They have enormous access. They have access to reviews of case records. They can interview state personnel. They might interview foster parents who are particular. Relationship with foster parents can be a particular problem for CYFD. And they can even interview children who have been in custody. So they have enormous, they can interview us if they want to know. I mean, they're not going to subpoena you, but you're free to talk with them. Everyone's free to talk with them. That is included in their measurements. What are the overarching themes? I'm not going to get into all the details, but there are really 4 foundational requirements. One is strengthening and stabilizing their workforce. That's true for CYFD and HSD. CYFD needs caseworkers, direct care staff, but they also need data people, as I've said. HSD needs data people, and they need more people, in my opinion. They wouldn't necessarily agree with this. I think they need more people to supervise the MCOs. Secondly, foster families or adequate, durable family placements need to be grown, need to be expanded in New Mexico. Thirdly, behavioral and mental health services are essential. We know, we'll talk about that in a bit, we know they're short. And then fourth, applying all of these better placements, better workforce and behavioral mental health services, applying those to the tribes and nations and pueblos of New Mexico. These are all interlocking when you think about it. One of the biggest problems in progressing in this is it's hard to do one of these without doing them all at the same time. One of the problems why caseworkers leave or don't want to get hired to begin with is because there's no services and there's no places to put these children. And so a lot of these have to be solved in unison moving forward. Workforce expansion is the first thing I'm just going to talk about. The agreement states that CYFD has to make a workforce recruitment and retention plan. They didn't quite make that on time, but they have made it since. And one of the reasons they didn't make it was because it didn't have a methodology for how they figured how many cases a caseworker should carry. There are national standards for that. So what is a caseload standard? It's the obvious. It's the number of cases that is optimal or the maximum number that a single worker can successfully manage. It applies not just to frontline staff like permanency planning workers, who we think of as caseworkers. It applies to investigators, placement workers, which are different, and ICWA-related caseworkers. So these caseload standards are a way of retaining and recruiting people when they're reasonable. They're not reasonable at this point, but it varies a lot, if you know what I mean, because counties are variously populated, some very sparsely and some more densely. This caseload standard is going to require, without a doubt, the hiring of a lot more caseworkers, and that's going to require budget, and that's going to require the legislature to get involved and fund that. They have to a degree, and they haven't to a degree. That's all I can say. And when you hire workforce for CYFD, which usually is caseworkers, it's not as simple as putting an ad in the paper. You know, there is a big, like I said, there's a run up to these things. They have to cultivate the pool of available hires, which they've done somewhat by making agreements and arrangements, but with various schools of social work. They have to be the right credentials in education. There's a lot of turnover, like I said, and they turn over partly because there aren't other services and because their job is impossible and their caseload is high. Salary is an issue. I have no idea why their salaries aren't higher, but they should be. A lot of caseworkers are not retained because the schools offer higher salaries than CYFD. So you can move to the school and do a reasonable job, or you can do a really hard job for less. Just being blunt about that. Placement reform, like I said, adequate foster families, but adequate placements in general is the second major pillar of this agreement. The full settlement agreement, the agreement between the state and CYFD and HSD states bluntly that no child under 18 will be placed in any hotel, motel, out-of-state provider, or state or contractor office. Those of us who work with children probably have lots of cases they've seen where kids are stranded in offices because they will come into care. How they could come in unexpectedly, but they do. They come in unexpectedly, or their placement disrupts, and therefore they're placed in offices. Like those children cannot be placed, and out-of-state providers I'll talk about too. That usually means RTCs, but it's not a preferred. It's not a preferred placement, partly because it's an RTC, it's congregate care to begin with. And then secondly, it's in another state. It's almost impossible to step these children down. Extraordinary circumstances continues to be a matter of debate, like what counts as an extraordinary circumstance that allows of out-of-state placement. The plaintiffs would say that not having an adequate placement network is not extraordinary. It's easily foreseen, and it's something that should not continue to be extraordinary year after year after year. As just a insight into some of the data problems that go on in CYFD, this is a slide collected from CYFD testimony to the Legislative Finance Committee in December of 21. The number of youth who were in out-of-state residential treatment centers, in this case, they said was 180. That's more than any of us thought. And I'm not sure it's accurate because in 2022, they presented to the legislature these figures. And the most that they ever had were 65 kids that were out of state. And that was back in 2019. So data is getting better. The past is a wash, trying to collect accurate data from the past sometimes. We do know now that it is accurate that in May, they probably had 24 kids. And we do know that now they're down to something like 14, 15, something like that. It's a moving target, as you can tell, and we know that. So that has been successful. Is it good? Again, we don't know where all those children went, and we know there's not adequate placements in New Mexico. So it makes us worry when the numbers drop and we don't know where they went. Nevertheless, it's an improvement and the number itself is getting better. Why is congregate care not a preferred treatment? I'll just restate what I said earlier. The developmental needs of a child are not met by being in a congregate care setting. There's lots of very good people in these settings, good therapists and good caretakers, but it's not the same. We've known since 1947 and when all these studies were done on orphanages that it just doesn't meet their needs for development. And moreover, the adolescents who end up in these placements oftentimes are not well served developmentally as well. One, they continue to need that one-on-one primary caretaker contact, but also the heart of adolescent development is experimentation. And it's hard to do that. There are cases where one kid propositioned, I don't know whether I'm using the right word or not, but made an overture to another kid. It wasn't explicitly sexual. It was more of an experiment, to see if they could make contact there, and we ended up being arrested. And so those kind of probably average foibles. I'm not defending that particular case, but I'm saying those average kind of foibles. You can raise your hands in your mind only. If you had anything to drink in high school, if you ever smoked weed in high school, if you ever not got in trouble in high school, it's part of the developmental course, and it can't happen in a congregate care. And lastly, it's self-reinforcing. The easiest thing in an emergency is to call an RTC. That's what I would do if I was in their position, is call an RTC and say, could you take this child? Because it's at least a safe place, or relatively safe. And so it becomes the default. Instead of having community-based home-like settings, it's an easy place. There have been times in New Mexico's history, and not that long ago, where children were in huge gulags of RTCs. There were a lot of kids in care in custody were in RTCs. So in pursuit of those improved placements, the full settlement agreement says that CYA and HSD both will make a plan to increase recruitment and retention of culturally reflective community-based treatments, basically foster families, community-based foster families, and throughout the state. Culturally reflective, I don't need to define that for anybody in here. I mean, I think you know what that means. There's a lot of cultural differences in different populations in New Mexico. And for example, ICWA itself, the federal law, ICWA, says that a child needs to be placed with a foster home that is culturally similar or equivalent to the home that they left. Based upon all the review and consideration, the state did make the plan. And in pursuit of that plan, the co-neutrals, the monitors, set a target for recruitment for the state, for how many foster families they hoped that they would get. That target was 89. They were able to recruit 59, which was 66%, which is progress. The settlement agreement also, you probably wonder why I'm throwing this in here now in the middle of this, but they also required that CYFD would publish guidance prohibiting retaliation. A lot of you don't deal a lot with CYFD and haven't dealt with them in the past, but one of the biggest problems in CYFD is that they would retaliate against people who criticize them either internally or externally, and that would be to the detriment of their placements. It would occur against foster families, it would occur against their own employees. It was a major problem, and it was a major problem for morale. It was one of the obstacles why foster families didn't want to work with the department. It was one of the obstacles why caseworkers sometimes didn't want to work with the department. So that's how it's related to the other target outcomes. They have made that policy. It's an internal policy, and I'll tell you something about it in a second. That's an internal policy for employees, foster parents, clinicians. Anybody can make a complaint of retaliation. They also have a specific Office of Children's Rights, which they have created since the Kevin S. agreement, and that gives the foster children themselves a place where they can contest. The problem with these two agreements is they go up the decisions and review of these cases. The complaint goes up through CYFD. So you're complaining and making a complaint against the department that makes the decision. I'm not saying that's necessarily bad, but it gives the impression of that you can't necessarily win one of those cases. Nevertheless, it is recourse, and it should be used whenever you yourself, or of people that experience that. It should be employed. The third leg of this is services. The settlement agreement requires for Medicaid, HSD, that is, Human Services Department, to create a behavioral health workforce development review. This is just the review. This is an IT, one of those planning things. In that review, there's a lot of moving parts. The HSD had to assess the utilization need, how many kids were going to be in custody, how many of those would need certain kinds of treatments, and then they had to assess the provider network adequacy, not just counting heads, but counting the number of people who actually deliver services to children, who deliver trauma-informed services to children, and the number of people who can actually meet this need. They didn't meet this requirement, and they're still working on it, the review, that is. And they didn't make it by the end of 2021. I don't think they've made it yet. They may have made it by now. Network adequacy is what I'm talking about in terms of behavioral health services. Network adequacy is supposed to be ensured by the MCOs. It's part of their obligation But the Legislative Finance Committee, who is known for investigating deeper than surface level, conducted a secret shopper survey, which you probably read about in the paper. But in that, they called and posed as Medicaid enrollees and asked both primary care and behavioral health providers. And they were able to get an appointment only 13% of the time. And so when you talk about adequacy, there have been reviews of the MCOs that actually said the provider network was adequate. And so I don't, it's hard to reconcile the 13% that could get an appointment and the adequacy of the network itself. I think possibly the answer is that the standards were set so low that the MCOs actually made those standards and had it approved. That's possible. But in any case, the network itself, adequate or not, you can't really get an appointment for most of the kids that you want to see, either for you who are sitting there listening to this, or for all the other kinds of things like neurologists or psychological testing or psychologists or therapy. In order to improve the MCO performance, there was a lot of new requirements in these RFPs that went out for new MCOs. These went out last year in September. The RFP was issued. Submissions, proposals were accepted, and they were ranked, and then they were judged. And the contracts were awarded. It turned out that Western Sky was one that didn't make it. And for some reason, we don't know why, the governor, after all that was done, canceled it abruptly. She just stopped the RFP process. And nobody really knows the reason for that, but that she does have in her sights making what she wants to call a health authority, which would take some of the medical, I'm not an authority in this, but a health authority would assume responsibility for healthcare in New Mexico on a broad basis, and they would change the name of HSD. So since these services are not here now, and since even at the very best estimates, the Medicaid has to go to CMS, has to go to the federal review, and they say the earliest that these new trauma-based therapies or the expansion of services can't really happen until the beginning of 2024, can't begin to happen until 2024, and probably won't be, the network will probably not be expanded until the middle of 2024, the last. We know how long it takes to cultivate a provider network. Since that's going to be a very long time, at least 3 years after the agreement sets, what can they do now? They can make, we're asking them to make what we call complex case agreements and single case agreements. Complex case agreements means they mix and match their services to actually address the needs of the child instead of retrofitting the child to fit the services that are available. That would mean they would mix service definitions, like take something like treatment foster care. It's a service definition, it's billed as a Medicaid service. You can't tamper with the definition and still get it billed according to Medicaid, but we know that you can do that. You can expand those service definitions and add more supervision, for example, to treatment foster care. So it would mean adding wraparound services. It might be adding psychosocial supports that may or may not meet the traditional definition of medical necessity. It basically is saying, what does this child need and how can we provide it? Medicaid will not pay for services that don't meet medical necessity requirements, but there's a pool of money that CYFD has and a pool of discretionary money that HSD has. We know that there could be money there for that. But like I said, the point is to offer them what they need. And finally, the Indian Child Welfare Act, the requirement of the agreement was that the state, HSD and CYFD would collaborate with the legislature and with us as the plaintiffs to codify federal ICWA law into state law. That may not seem like a big accomplishment since the federal law mirrors this in some respects, but it is because the federal law is highly at risk with the current Supreme Court. And like I said, ICWA requires that children who are taken into custody, it requires a few things, but children who are taken into custody have to be placed with tribal members or people who are culturally similar in order to preserve their own cultural identity. And that means that foster families have to be recruited within the tribes as well. One of the other requirements, I think I mentioned this before, for CYFD was that they create a screening instrument and apply that screening instrument to all the children in custody so they know what these children, in some sense, at least in a broad sense, what they need. That they decided to use the Child and Adolescent Needs and Strengths, the CANS, that you're all, some of you are familiar with. CANS is a screening instrument. It's a relatively large, a relatively detailed one. And the emergency version of that for children just coming into custody is a short version of the CANS, and it's called the CAT, the Crisis Assessment Tool. These are not diagnostic. They don't even identify, if they identify that a child has social emotional problems or school problems, it doesn't really identify the source of that. And as we know, a child with school problems can have anything from hearing problems to anxiety to a learning disability, but it requires that they center and get further evaluations for those needs. And the CAT and CANS is currently being rolled out at a very slow rate. It's not meeting the requirements, but it has been developed successfully. The instrument itself was developed and approved by the co-neutrals. So what can we do as clinicians? As a clinician, you're going to see these children and you can ask for the treatments they need. Demonstrate the need for more, for better, and different services, and then document that. Put it in a record. Secondly, you can refer for necessary specialty evaluations, whether those are psychological testing, neuropsych testing, or psychological testing, projective testing, or whatever you think that child needs. Refer for it. Refer to pediatrics, refer to neurological, for neurological evaluations, and document that. When the services don't fit the child, ask for complex case agreements. Who do you ask? You ask the care coordinator, and they have lots and lots of new duties. Care coordinators, certainly the ones you're seeing through, I'm forgetting the name of the, I'll recall it in a minute, but there are some working within the hospital who are tremendously effective, but the ones statewide have not been that much help, partly because they're not magicians. They're supposed to access care and there isn't care out there. And so they have trouble themselves, but ask the care coordinator. They have lots of new responsibilities. They're supposed to pass that request on to the MCO, who's supposed to be in the process of developing that. Primarily, since placement is the issue oftentimes. With children, placements are treatment. A secure placement is the best thing you can ever give a child. It doesn't answer everything, but it answers most of their developmental needs, and it gives them an advocate. So request services that would avoid disruption of placement. And then again, this is redundant, but ask your MCO care coordinator for these new services. If you need a complex case agreement or a single case agreement, ask the coordinator. You ask them to locate evaluations, ask them to locate planning meetings, ask them to attend the team meetings. There's a lot you could ask them. They're good people, and I think they're going to be trained differently and differently obligated going forward. if you have questions or things that you would like to report to the people who are, it could be go to CYFD, that's for sure too. But if you want to report ideas, or you have ideas, or you would like to collaborate in any kind of way, these are your contact points. Pegasus is one of the plaintiffs. The implementation team is a team that is working on assisting the state in getting these things done. Office of Children's Rights, I referred to earlier, it's internal to CYFD. It's run in a way that will be receptive to your requests and disability rights. And so with that, I think I'm going to put an end to this. And if there are any questions, feel free and launch. After monologuing for that long, you probably are all in a mild coma, possibly.
Dr. Davis, there was a question in the chat. Are there any planned or anticipated changes being created regarding placement processes depending on the Supreme Court's ruling on ICWA?
Yeah, that's the ICWA law. That is the Indian Child Welfare Act. One of the changes that has occurred is that it has been codified in state law as well. And yes and no. All of these things, like the inadequate workforce, the inadequate placements, apply in particular to Native American children. And so recruitment efforts are being made within the tribes and the nations and within the Pueblos to recruit those kind of foster parents, to offer them support and training, to reach out and collaborate with the Native American tribes. That is the effort, and to also to increase services that are applicable to Native American children. The other thing that's been done is funds have been allocated in order to provide things like ceremonies and other kinds of native friendly kinds of treatments. That's what's been done. Any other questions?
I did have a question. Do you know if there's any other states that have had similar kinds of lawsuits against like their children's social services, and if so, like how successful those states have been in like meeting the requirements?
That's a great question that I wish I had actually addressed. It's an excellent question, because yes, we've looked to other models. There are similar efforts going on in Oklahoma. There's going on in Texas. One of the co-neutrals was the equivalent of the Secretary of CYFD in New Jersey during this settlement agreement, which is where he got all of his national experience. Those states, it went on in Washington. There's a number of states that are equivalent. And yes, we've learned a lot from that. Partly what we've learned is how complex system reform is. And that it has a natural course. I mean, if you compare it to something like the reform of Albuquerque Police Department, you know, it takes a long time to get that ingrained into the system. So we've looked to them both for ideas, and a lot of the agreements in Kevin S. were based upon other lawsuits, and we've looked to them for encouragement as well.
And the chat has just had, some thank yous for this wonderful presentation, which I will echo. Any other questions? People could either speak up or put a question in the chat. Well, I see we're just about at time. Thank you so much for joining us today, Dr. Davis. We greatly appreciate your time and expertise.
Thank you so much. It was a pleasure to be here, and I appreciate everybody who came. Thank you.